Hello, everybody, and welcome back. This is Peter Pronovost, and we're going to discuss nurse empowerment today. We know that the whole care team is essential for the success of these projects, but particularly the nurses are kind of the backbone of this ICU work and quality improvement, and we have to make sure that they are empowered to help facilitate safe care. At the end of the day, we have to look at Sorrel King, Josie's mother, and tell her that care is safer. And that's only going to be happening with substantial engagement and empowerment of the nurses. So our objectives today are to help understand the importance of nurse empowerment and to offer some strategies that we've seen that help with empowering nurses in this vitally important work. Now, as you remember, we've kind of broken up work into technical work and adaptive work. And the technical work is summarizing evidence and developing measures. And we're doing that centrally. We're trying to help make sure that happens. The adaptive problems, though, are really your leadership. They're how do we get culture change? How do you empower nurses? And we've offered you a variety of tools like CUSP and daily goals. But this session is specifically on getting nurses empowered. Now, part of empowerment is being perceived as being trustworthy. And we know that being trusting is underpinning so much of our effort to do this work, but we haven't really thought about what it means explicitly. And I see trusting as really two key pieces. You have to be caring and you have to be competent. And how are you perceived as being caring? Well, that you are all the time having patients as your North Star. That is, there's no hidden agendas. There's no question about what your priorities are. There's no self-gain. It is about patients and they're your North Star. Caring is also when you have the courage to say, harm is not tenable here. That we are going to commit to eliminating preventable harm. And lastly, when you have the courage to tell your own Josie stories. That is, you can confront your current reality, and in some cases, it's not very pretty. We know you're committed, but harm is happening, and we're not going to address the problem until we have the courage to start telling our own stories, just like Josie has in my institution. And we have to be perceived as competent. And in quality, competent is that you commit to learning from mistakes, not just recovering, and you implement these tools and strategies to eliminate bloodstream infections and to improve culture. What model are we doing in this work? Well, as you remember, we're trying to do the 4 E's. That is, we're engaging, educating, executing, and evaluating. And we have 3 groups of stakeholders, of people who we have to walk through these 4 E's. And they are your senior leaders, your team leaders, and your staff. What we're focusing on today is the backbone of this work. It's your frontline staff. And unfortunately, in so many quality improvement efforts, the staff have been neglected. They don't come to the energizing sessions or the collaborative meetings that the team leaders do. They're back in the trenches doing the really important work of caring for our patients. And so we have to make sure we have a mechanism that they're supported in their daily work, that they're realizing the importance of what they do, that they understand that what they're doing is making the world a better place. How might we begin to empower nurses? Well, I ask you to think about this at 3 levels. There's an internal level, there's your ICU team level, and then there's a policy level. Internally, we have to keep reminding all of us that patients are our North Star. They're the guiding light. They're why we're here. They provide meaning in our work. And so we have to keep that message front and center in all of our efforts. We also have to encourage people to have the courage to speak up, to empower nurses, for the nurses to stop central line placement if someone doesn't wash their hands, or to say, hey, you don't have your gown on, let's go back and do this, is an active decision. And that decision to speak up is only going to happen when nurses feel competent, when they feel it is safe, and when they feel it's going to work. That is, their actions are going to be listened to and rewarded. So you have to create an environment that makes staff feel competent, that they feel it's safe, and they feel it's going to be effective. How do you do that? Well, you make them feel competent by knowing that the evidence supports what they're doing, that this isn't shooting from the hip, that they know there's evidence supporting hand hygiene and they're going to advocate for it. There's evidence supporting using full barrier precautions and they're going to advocate for it. How do I make them feel safe? Well, I give people the ability to practice speaking up in safe ways. That is, we make it a policy that when we're putting central lines in, it's okay for the nurses to speak up. Because once you do it in one safe place, it spills over and it grows. Just like when you drop a pebble in a pond, it starts with one little ripple and it spreads across a whole lake. We have to allow people a safe place to practice these behaviors. You can tell them to do it till you're blue in the face, but unless they feel competent, unless they feel safe, unless they feel it's actually going to work, you're not going to see behavior change. And lastly, you need to support nurse empowerment at a policy level. That could be a code of conduct, but you have to make sure your organizational policies support nurses speaking up. What might be some programs that support nurse empowerment at a policy level in this program? Well, first, have a code of conduct. Say, this is how we will treat each other in our hospital, in our ICU. You can create a policy that says nurses will assist with every central line placement and that they are required to ensure that the checklist is adhered to. Without these empowerments, a checklist is likely to be useless. It's just a piece of paper that no one will use to have behavior change. But when we create a safe space, it may actually lead to its use and reducing infections. You also could have a policy to deal with disruptive behaviors. And what we're learning more and more is that disruptive behavior isn't just with physicians and nurses. It's as likely to be nurse within nurse, the senior nurses having disruptive behavior with the more junior nurses. And we need a policy that says this is how we're going to deal with it within your institution, within your culture, with your resources. You could also have a policy that says nurses are so important that we require that they attend daily ICU rounds. What a powerful statement, that rounds will not proceed unless that bedside nurse is there, because he or she is absolutely vital and essential to delivering safe, high-quality care. So what are some strategies that you can consider using? Well, you have to provide tools that nurses could practice empowerment and speaking up in a safe space. I strongly encourage you to say, in our ICU, nurses have to attend rounds. Another great strategy is to say nurses will use the daily goals and they will read back what the plan of care is. That is, unless they make the care. In our ICU, the physicians make the plan with the whole team's input, but then the nurse reads it back so we don't have a decoding error. That is, we don't risk having that nurse translate what the plan is into a different plan and end up not in a place we don't want to be. And you can continually say, we're going to learn from our defects. So when we have communication problems, there's a mechanism to not just recover, but to learn from them. I also encourage you to have a plan to address disruptive behavior quickly. That is, you need to have a code of conduct that guides behavior, and when there's digressions from that, it is addressed. And remember, this disruptive behavior is not just physician-nurse, but it's nurse within nurse. I also encourage you to keep the focus in any of this conflict on this patient. If you try to solve who's right, you're going to lose. There's no truth in this. Truth is whosever perception you try to believe. That is, we all have our views of the world. We all have decoded the events in our own meaning. But what we could say is, in this situation, the patient is the North Star, and what are we going to do to ensure that she gets the care that she needs? And lastly, I would encourage you to remind your staff all the time that teams make wise decisions with diverse and independent input. So listening to the nurse, listening to patients, listening to their families isn't a nicety. It's essential if we're going to give high quality care. You remember we made the metaphor from soccer or hockey or lacrosse of being in a penalty box. And when you're in a penalty box, you're man down and you're substantially disadvantaged. It's a silly way to play. You're going to lose, and we can't afford to play man down in healthcare. So continually remind your staff, don't play man down. Speak up when you have concerns and listen to others. Listen when others do. So what are some strategies for you as an action plan? Well, meet with your ICU team and discuss how empowered do your nurses feel. Discuss how comfortable they are speaking up and questioning physicians about use of the checklist for preventing catheters, of using the daily goals. And when they don't feel empowered, develop a plan about what you're going to do for that. Remember, they have to feel competent, they have to feel safe doing it, and they have to feel it's going to work. So make sure that you address all these things. If they're not competent, develop some program to help them get confident. If it's not safe, say, let's just try this one toolkit, reading back daily goals or using the bloodstream checklist in one small place, and you'll see it mushroom and grow like that pebble dropped on the water. Discuss what policies you can do. Should you have a policy that says nurses will assist central lines and they are allowed or empowered to stop takeoff if the checklist isn't used? Again, without this nurse empowerment, the checklist will be nothing more than a piece of paper. Think of strategies you can use to involve all your bedside nurses in this project. Remember those 4 E's of engagement, educating, executing, and evaluating. And if those 4 E's don't get down to the bedside nurses, to the nurses who are there day in and day out delivering care, this project won't work. So whether you're going to use e-learning modules, and we hope you take advantage of the ones we provide for you, or you're going to give these sessions yourself, or you're going to have in-services, you need to use your leadership to decide what's best for your ICU, but you have to make sure you are actively walking through the 4 E's with all of your bedside staff. That is, they know how this project makes the world better. They're completely clear about what they need to do. They know what they need to execute, and they understand how you're performing with your infections because you're evaluating and you're giving them feedback. Lastly, I'd ask you to discuss what tools you can use to enhance nurse empowerment. That is, there's a lot of things in here that we've discussed with you, and not all of them are going to be right for you or your ICU, and you may have new ideas that we hope you share with us and we could all learn from you. But you need a concrete plan to make sure that your nurses feel confident speaking up, that they feel it's safe when they speak up, and they feel that when they speak up, it's going to work. That is, someone's going to listen and it's going to be acted upon. And without that, I fear at the end of the day, we're not going to be able to provide Sorrel King with the answer that she needs. But with it, I am completely confident that you, just like we've seen in the 103 ICUs in Michigan, will be able to look Sorrel in the eye and say, yes, we know you're safer, and the nurses played an incredibly and powerful role in getting us there. This is Peter Pronovost, working with you to improve patient safety. Have a great day.